Hello, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Chris Hudspeth, the radio program manager for MS Focus Radio, and we're joined today by Dr. Ben Thrower, speaking with us about MS and vision. I can see clearly now. After this presentation, we'll open it up to your questions and comments. Dr. Ben Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta, Georgia. He previously served as the medical director of the Holy Family MS Center in Spokane, Washington, and he is the senior medical advisor for the Multiple Sclerosis Foundation and enjoys contributing to our quarterly MS Focus magazine. When Dr. Thrower isn't dressing up as Jack Sparrow the pirate, he can be found playing with his new grandson, Sam, and now on a farm, playing with tractors and growing things. We're pleased to have him join us today to present this important topic about vision. Dr. Thrower, it's always a pleasure to have you. Thank you for being with us, and I'll turn it over to you.
Great. Thank you very much, Chris. And as always, thank you to everyone behind the scenes at MS Focus. We appreciate everything that you folks do in getting education out and keeping things running so smoothly during the COVID pandemic. Thank you to everyone in the MS community who's joining us this afternoon. So this is a topic that we don't always touch on very much, but it's obviously hugely important, and that's vision in multiple sclerosis. How can MS affect the vision? What are some things that are not related to MS that people might struggle with from a visual standpoint, and how do we separate those two things out? So the three main areas that I wanted to touch on as it relates to MS and vision are optic neuritis, diplopia or double vision, and nystagmus or bouncy eyes. These are three of the more common things that MS could throw at you in terms of visual challenges. Optic neuritis would be the most common visual symptom we see with MS. For many people with MS, this is their initial presenting symptom. It's one of those MS symptoms that you really can't ignore. If you woke up one day and you had a little bit of numbness or tingling in a foot, maybe you can think of 1,000 reasons why your foot's doing that. Maybe in people who are not diagnosed, they just write it off to a new exercise program or an injury. It's harder to ignore optic neuritis. If you wake up one day or during the day, your vision suddenly changes, you're probably going to pay attention to that. So optic neuritis represents inflammation in the optic nerve. The optic nerve is a direct extension of the central nervous system. It's about that long. It comes off of the brain, drops under the bottom part of the brain, and goes right into the back of the eyeball or the retina where it dead ends. Then you have retinal nerves that spread out along the back of your retina, collecting that visual information as it comes into your eye. One of the more common symptoms that we're going to see with optic neuritis is blurred or lost vision. Usually it's in the center part of your vision. It's usually going to be one-sided, although on occasions it can be both eyes. When people present with optic neuritis, one of the cues that maybe this is not MS is if it's both eyes. So there's a cousin of multiple sclerosis called Neuromyelitis Optica, or Devick's disease, which would more commonly cause bilateral optic neuritis or optic neuritis in both eyes. Usually this is going to come on rather suddenly. This is not something that builds up over weeks and months. It's going to be, either hours to a couple of days until it's at its worst. Many people with optic neuritis say it's uncomfortable. Usually the discomfort is behind the eye itself. And when people track with their eyes, because you're actually moving the optic nerve, when you move your eyes, it can be a little bit more uncomfortable. So deep aching pain behind the eyes. One of the other symptoms that we see with optic neuritis is called red desaturation. That means that certain colors, especially red, look washed out. So one of the tests that we do for optic neuritis is give you something that's bright red to look at. And if it looks kind of pinkish in the affected eye, that's one of the more common symptoms. So the bottom, the red card at the bottom is these are some of the ways that someone might see an object in an affected eye with optic neuritis. So when we're thinking about optic neuritis, one of the things we would really like to do in a perfect situation is have you get to your ophthalmologist and get someone to look at you acutely. You know, if you've got a good relationship with your eye doctor already, you know, sometimes we can have you call them, they'll get you in the same day. Maybe it means going to the emergency room. Um, Part of the reason we want you to see your eye doctors, we want to make sure there's not something else going on. There are things that can mimic optic neuritis that we'll talk about later that we wouldn't want to miss because the treatment pathway for those other conditions might be very different. One of the tools that we sometimes use is optical coherence tomography. So the person and the gentleman in the blue shirt is looking into the OCT or optical coherence tomography machine. And what it's going to do, it's going to print out the picture over on the other side of the slide. So we get a very detailed picture of your retina and your optic nerve. So traditionally, when you go to your doctor and we have an ophthalmoscope, the little handheld device, and we're looking into your eye, we're getting a look at your retina and your optic nerve. We get a whole lot better picture of your retina and optic nerve with this OCT machine. An analogy would be, imagine that you have a door closed to a room and you're looking through the keyhole of that door, and someone asks you to describe the room by looking through the keyhole. So you're peeking through this little tiny hole and you're trying to see different parts of the room to give a description of it. Now, what if someone lets you open the door up and see the room? That's the difference between using an ophthalmoscope and using something like OCT. We're seeing with OCT, we're seeing everything just beautifully laid out in front of us, and you know, just magnitudes different way of looking at the optic nerve and the retina. The other thing we can do with OCT is we can measure the thickness of your optic nerve and the retinal nerve fiber layer. So that right at the bottom of those graphic pictures, let's see if I can use my arrow here, down here are these little pie-shaped graphs. And so what they're doing is they're dividing the retinal nerve fiber layer up into quadrants. On most OCT machines, anything that's green is good. That means you have a normal thickness of the retinal nerve fiber layer. When you get into yellows and reds, that means it's starting to thin. It's been damaged somehow. If it's an acute optic neuritis, you may actually have swelling, and most of these machines, swelling is going to show up as blue on these pictures. So you'll see, so in the affected eye, there may actually be an increase in the volume of the retinal nerve fiber layer or the optic nerve. One of the things we can also do with OCT, not so much important in optic neuritis, but maybe in other conditions, we can look at your macula. So certain MS drugs, things like the S1P receptor modulators, these would be Gilenya, Zeposia, Mayzent, and Ponvory. These drugs carry with them a little bit of risk of macular edema or swelling in the macula. So we like to make sure that people have a healthy macula before we start one of those medicines. And the OCT is one of the tests that we can do to show that you've got a nice healthy macula before we start one of these drugs. So let's say we've diagnosed optic neuritis. What are we going to do about it? Traditionally, we're going to think about using steroid medications. Typically in the US, that's going to be IV methylprednisolone or solumedrol. We're going to give 1 gram a day for 3 to 5 days. We may or may not do an oral steroid taper afterwards. We can also convert that methylprednisolone into high dose oral prednisone. Typically, that's going to be 300 milligrams twice a day for 3 to 5 days. Studies have shown that really the effectiveness of the high dose prednisone versus the IV methylprednisolone really appears to be equivalent. Maybe you've had steroids and you didn't get any better with it, or maybe you can't tolerate steroids. There are certain people that were a little bit nervous about using steroids, and people with diabetes or hypertension, for instance. Or maybe you have mood changes with steroids that make it not very appealing to you. So we could use IV immune globulin. That's typically going to be a 5-day course of IV immune globulin. If it's a really bad optic neuritis and maybe you've not responded to any of these things, on rare occasions, we do use plasma exchange. That's usually going to have to be done in the hospital, though, to do the plasma exchange. So put observation on there. So is doing nothing an option for treating optic neuritis? And it can be. So many years ago, there was a large study called the Optic Neuritis Treatment Trial. And what they did in the Optic Neuritis Treatment Trial is looked at treating people with the high dose IV steroids versus a group that got low dose oral prednisone versus a group that got nothing. They were just observed. When you looked at these individuals at the 1 month mark, the individuals who got the high dose IV steroids were better than the other two groups. If you looked at these individuals at 6 months, all three groups looked the same. So what we think steroids do in optic neuritis, and really we think this probably applies to most MS relapses, is we think IV steroids make you better faster, but they don't change the ultimate recovery. So is doing nothing for optic neuritis a potential treatment option in multiple sclerosis? Maybe. Generally, most people with optic neuritis aren't thrilled about the doing nothing option, though. You know, putting up with a numb foot is very different from putting up with visual loss, because it's so much more potentially disabling and has such bigger effects on your activities of daily living, putting up with visual loss in an eye. So it's rare that we do nothing for optic neuritis, but you could argue that academically it is an option, and ultimately your recovery would be the same. So, oops, one more here. That slides are going a little happy. So one of the other things we should mention when we think about treating optic neuritis is not just focusing on treating it after it's happened, but really focusing on preventing it in the first place. So optic neuritis, like any MS relapse, we would like to think about preventing it. And the way that we prevent any MS relapse is by having people on an appropriate disease modifying therapy. So we're up around 22 FDA approved treatment options right now. So, after we put the fire out of optic neuritis, we're going to want to step back and say, okay, how do we help not have this happen again, and have that discussion about, are you on something right now? If you're not on something, let's get you on a treatment. If you are on treatment and you've still had optic neuritis, do we need to think about adjusting that therapy to keep this from happening again? So taking a little side journey for a second, one of the common questions that we get is, I've had optic neuritis in the past and I got better from it, but now I feel like my vision's just slowly changing over time. So it's not an acute change, it's just more gradual. And so what we do need to realize that is in the background of a person having MS is that there's normal human aging, and all of us are at risk for our vision just changing due to normal maturation over time. One of the ways that we try to separate out is this old optic neuritis or new optic neuritis, or is this maybe just the need for a lens change? Can the eye doctor make the vision better by flipping a lens in front of your eye? Any visual change that they can refract or make better with the lens is not likely from your MS. Changes from optic neuritis don't get any better with a new pair of glasses or contact lenses or LASIK surgery. So if your eye doctor can make it better with a lens, that's wonderful. That's not your MS doing that. So shifting to the second visual issue that we see with multiple sclerosis, and that would be diplopia or double vision. So your eyes are designed to move in perfect unison and track perfectly together. If they're off by even just a little bit and they're tracking, you're going to get double vision. Sometimes that sort of misalignment can be so subtle that for us in the exam room, we may not really even notice it. But even just 1 degree of misalignment is going to be enough to give you double vision. So if it's really out of alignment, people will say there are 2 images. And so double vision can be what we call horizontal, those images are side by side. It can be vertical, one image on top of the other, or it can be askew, where there's sort of off skewed sort of in a diagonal direction. All of those are forms of diplopia or double vision. Double vision should resolve if you cover one eye. So by covering one eye, you're taking one of those images out of the equation. If your vision does, the visual symptoms that you're having does not improve with covering an eye, it may not be traditional diplopia. There may be something else going on. So when we think about treating double vision, if it's an acute change, you woke up one day and bam, there's double vision there, that may be an MS relapse, and we may treat it with steroids just like we would with any other MS MS symptom. So if it's more chronic, it's been there for months or a year or more, one of the ways that we can potentially treat that is just like you would cover an eye. We can just have you patch an eye to take one of those images away. We need to have people be aware, though, that if we patch an eye, you're going to lose depth perception. So now things have become very two-dimensional. That can have implications for maybe increasing fall risk. It can have implications if you're driving or riding a bicycle. You just need to be a little bit more cautious if we do patch an eye because of that loss of perception. One of the other questions that sometimes comes up with double vision of a chronic nature is, can we have an eye doctor make Prism lenses? So if one of the images is off because your eyes are not lined up, what if we put a prism in your glasses to bring that image back into alignment? It's a great concept, but one of the challenges that we have in multiple sclerosis is that, like so many symptoms in MS, the degree of double vision that you may deal with is going to potentially fluctuate through the day. People with MS have nerve fiber fatigue. In other words, the areas of old demyelination, they work to different degrees throughout the day. So a lot of people have better neurological functioning in the morning, and as the day goes on and they fatigue a little bit, they're having more and more weakness, more visual changes, more double vision, more fatigue. And so a prism lens that may be perfect for you at one time of the day, as you fatigue or have more energy, may not be correct for you. So what we find a lot of times with prisms is they work part of the time, and they may actually make the problem worse at other times. So it's not always a great option for people with MS. So nystagmus. So nystagmus is a bouncy eye, basically. So it's involuntary rhythmic movements of the eyes. And so a lot of the coordination of eye movements. So we talked about double vision, how the eyes should track together. And a lot of that sort of coordinated tracking is coordinated by the cranial nerves. So it's, in particular, cranial nerves 3, 4, and 6 off of your brainstem. Nystagmus is a little bit more complicated in that there are a lot of different areas of the brain, areas in the brainstem, areas in the cerebellum that can give you nystagmus. Nystagmus may result in you experiencing things bouncing in your visual fields. So when we look at your eyes, we can see your eye bouncing around. If that bouncing is significant enough, you're going to see images in your visual fields bouncing around when you try to look at them. There are a couple of different forms of nystagmus. So I'll show you here. So this video is going to show you a gentleman with horizontal nystagmus, where the eyes are actually going to be beating sideways. I'll start this up here. It takes a second for them to start going. You can see his eyes kind of bouncing sideways. What's interesting in this video, I picked it because it's so obvious. This is actually not a person with any pathology. This is a person riding on a train, and what they're doing is they're just trying to follow things as they're going by. So there is normal sort of nystagmus as you're trying to track objects if you're in a vehicle. But this is what horizontal nystagmus would look like potentially in a person with multiple sclerosis as well. So the next one is a person with vertical nystagmus. This one's a little tougher to see, but what we're kind of looking for is the eyes sort of bouncing downwards. I don't know if you kind of noticed that, where his eyes kind of took a couple of bounces, like they look at a ball bouncing off the floor up and down. So that's a form of vertical nystagmus. And then the last one is probably one of the trickiest ones to see, and that's called rotary nystagmus. What's going to happen in this person, so the eyes aren't bouncing horizontally, they're not bouncing up and down. If you watch the person's sort of iris, the dark part of the eye, they're actually rotating this direction. It's a little harder to see, but they're actually just rotating a little bit. And this is why your eye docs get paid the big bucks, because they can see this stuff. So that's a form of rotary nystagmus. So those are all things that we can see in multiple sclerosis. Let's see here. So nystagmus is a tough one to treat. We don't have, again, if it comes on acutely and it's part of a relapse, we're going to manage it with steroids just like we would any other relapse. If it's a more chronic symptom, we frequently get a neuro-ophthalmologist involved, but it's a tough one. I will say there's a quirky treatment out there that we sometimes use for the rotary nystagmus. We sometimes use off-label drugs to try to treat that. There really is no FDA-approved treatment for the rotary nystagmus, but there are some things we try to pull out of the toolbox occasionally to help manage that. So I threw this one in as well, myochimia. This is a pretty common symptom. It really does not affect vision, but because it's around the eye, I wanted to mention it. It's one that sometimes scares people a little bit, and it really shouldn't. So myochimia is just a really annoying twitch that you get in your eyelid. It can be in the upper lid, it can be in the lower lid. It feels to you like there's an earthquake. It feels like it's just, gosh, it's got to be so obvious to anyone else. Someone, to the casual observer, they're going to have to get really right up in your face to see that. Although it feels like an earthquake to you, it's actually very, very subtle. It's because these muscles are so sensitive that it feels so big to you. The good news is it does not affect your vision. It tends to sort of wax and wane. It'll come and go. It tends to get worse with stress or sleep deprivation, fatigue. Sometimes caffeine will make it a little bit worse as well. It may run a course over a few days or a week, and then it'll go away. You can see it in people without multiple sclerosis, but it's certainly a lot more common in people with MS. It's a form of muscle overactivity. You could say it's kind of in the family of spasticity in some ways. If it's tremendously bothersome to someone, we sometimes have medications like carbamazepine or Tegretol or oxcarbazepine, trileptal, that we can use to try to tone down some of that muscle hyperactivity. But usually people are not so excited about treating it as much as they're just knowing what it is and being reassured that it's not going to affect their vision. So there are things that people with MS can have that affect their vision that are actually not from their MS. We're going to talk about refractive errors, which we touched on a little bit already, migraine equivalents, detached retina, and glaucoma. So refractive errors, this is just the routine, I need new glasses. So blurred vision that can be corrected with the lens. Again, the vision changes from MS are not going to be correctable with the lens. The most common refractive error is just as we get older, we need readers. So I don't know how many of you are like me, but I have readers in every room of the house. I have a rule: I never spend more than $15 because I'm bound to sit on them, step on them, drop them in the lake, or do something else horrible to them. So I tend to lose them with great regularity. Migraine equivalents. So migraine equivalents are sneaky, and they're probably more common than most people think. So migraine headaches in many people are preceded by an aura, sort of a warning, if you will. And so one of the more common auras of a migraine are visual symptoms. People will have flashes of light, wavy lines, fireworks going off. They'll miss part of their center vision. Usually those visual symptoms are going to last for 20, 30 minutes. As those go away, then the person's going to get the typical migraine. A migraine equivalent is the unusual neurological part, including the visual symptoms, without the headache. So if you had the typical visual aura, and then you get a throbbing, pounding headache with nausea and vomiting, that's pretty, we're going to know that that's a migraine. What if you only got the visual symptoms? That's a little bit trickier. So those are called migraine equivalents or ocular migraines. Again, they're going to last typically 20 to 30 minutes. There can be flashing, sparkling, missing spots in the vision, any number of symptoms that we can see with these migraine equivalents. This is what these would look like in real life. So this kind of smudgy white light, loss of vision in the center, this kind of smudge with this rainbow around the outside. Could be just loss of the peripheral vision. There's a fine line between, at what point, if you have something like this, should you get to an emergency room versus wait it out and see? It's hard to give a definitive answer, because if you've had these before and you have a known history of migraine, you may be pretty comfortable just saying, I know what this is. I've had it in the past. If it's the very first time it's ever happened and it's lasting more than 30 minutes, it's probably worth going in and getting something checked out, just to make sure that it really is benign. So retinal detachment is one of the non-MS visual changes that we do not want to miss. This is a true medical emergency. So with retinal detachment, you have the back part of the retina peeling away, if you will, and so you're going to get visual symptoms with that peeling away of the retina. It can be the sudden appearance of really impressive floaters. Floaters are pretty common. Most of us have them at some point, but this would come on very suddenly, and there are a lot of them, and it's usually going to be off in your periphery of your vision. Sudden onset of flashes of light in one of both eyes. And this gets tricky because the migraine equivalents can give you flashes of light also. If it lasts more than 20 minutes, one of the reasons we want you to get to the emergency room is because maybe it's not a migraine equivalent, maybe it's really a retinal issue. And again, this needs to be treated soon. Blurred vision in one eye, loss of peripheral vision as that retina peels away, curtain-like shadows over your visual field. Again, we want to get you to the emergency room and have an ophthalmologist take a look at you soon with that. It can be treated surgically, but time is of the essence. Glaucoma is something that we want to keep in the back of our mind. So glaucoma results from increased pressure within the eye that damages your optic nerve and your retinal nerve fiber layer. It is still the leading cause of blindness in the US. I sort of equate glaucoma sometimes to hypertension, and that it's sneaky. People may have it and they don't know they have it, and it sort of gradually, takes things away from them. So the way that we might diagnose glaucoma is with a regular eye examination. They're going to measure the pressure in your eye. They can do it with a little puff of air that when you go to your optometrist, they can actually use something called a tonometer, where they numb your eye and put a little device on the surface of the eye to measure the pressure. We can also pick this up with the OCT machine that we mentioned earlier. So if you have really drastic thinning of the retinal nerve fiber layer, and it could be from your MS, but what if it's something else? What if it's actually something like glaucoma that damages that retinal nerve fiber layer? There are chronic and acute forms. The chronic is a little bit more common, so this is going to be something that's treated over the person's lifetime. Acute forms come on very suddenly, and that's a surgical emergency when those pop up. This is what visual changes look like with glaucoma. So you have a person with normal vision. So glaucoma tends to affect the periphery of vision, and over time, what it does is it just narrows things in until you're really having a tunnel vision. It can affect central vision also, but again, it's usually this sort of pattern over time. And with that, so that's kind of a whirlwind tour of all of the things that MS could potentially throw at you from a visual standpoint, and some non-MS things to think about that you could still certainly experience, but are not directly related to your MS. And Chris, with that, we'll throw it open to some thoughts and questions from the audience.
Sure. Thank you so much for that, Dr. Thrower, and we are ready for comments and questions. If you have one, please, you can use the raise your hand feature in the app, or you can send your question through the Q&A. If you'd like to ask your question directly, look for the raise your hand feature at the bottom of the Zoom screen, and then click it, and I will unmute you. A button will appear on your screen asking if you'll allow me to do that, and then select allow. We do have some questions that have already come in. One of the first ones is, can any ophthalmologist diagnose or treat optic neuritis in MS patients? And second to that is, are all ophthalmologists trained to treat MS patients?
Yeah, so I think most ophthalmologists are really well qualified to do what we need to do in MS to make the diagnosis of optic neuritis. There are ophthalmologists and there are neuro-ophthalmologists. Typically, we don't need to go straight to a neuro-ophthalmologist. And I think the advantage of starting with a general ophthalmologist is, so we wanted to think about optic neuritis or some of the other MS-related conditions, but we also want to rule out other non-MS related eye conditions. And I think sometimes starting with the broader general ophthalmologist is the way to go. You know, if we have someone that's got a really difficult, you know, MS-related eye problem, that's usually when we bring in the neuro-ophthalmologist. So yes, I think most general ophthalmologists are really well qualified to make the diagnoses. Whether they actually prescribe steroids for optic neuritis that's where the variability is probably going to come in. So they may say, listen, you've got optic neuritis, you need steroids, but I don't do that. They may contact one of their neurology colleagues to actually, or internal medicine colleagues to prescribe the steroids. They may be perfectly comfortable giving you the steroid medicine. So that's probably the only variation that I see between ophthalmologists, is whether they're comfortable prescribing the steroids.
All right, another question. Are Prism lenses permanent or for a period of time?
Yeah, so everything with MS is potentially reversible. So, you know, at what point do we call an MS symptom, including double vision, permanent? Usually we think about things as being permanent when they've been there for a year or more, but we have to be humble and realize I have seen people have MS symptoms resolve even after they've been present for a year. So typically, you know, we're going to start thinking about something like prisms to treat double vision after the symptoms have been there for a year or so we're pretty comfortable that they're permanent.
Another question from the Q&A is, glaucoma more prevalent in MS patients?
No, so glaucoma is no more common in the MS community than anyone else. It's just, unfortunately, glaucoma is just common. It's certainly more common in the African American community than in other communities, but it's not, MS is not a risk factor for glaucoma.
All right, let me go over. We have a question from Karen. She's been having her hand's been up for a while. Hope her arm's not tired. This is let me say allow to talk. All right, Karen, go ahead.
Unmute. All right, can you hear me now?
Yes.
Okay, thank you. Last summer, I had extreme vertigo and nystagmus. I mean, I sat up in bed and literally my body was just threw me back. A year and a half ago, I was diagnosed with MS. Some of the doctors think I have primary progressive MS. I had no vision loss. My neurologist thought that it was crystals, inner ear crystals. And it was sort of resolved by doing that, forgot the name of the maneuver, but Uftop or something like that. You lay down and
Yeah.
you know, switch your head back and forth, which seemed crazy. Is there any way that was related to my MS?
Yeah, so when you have vertigo, so vertigo is your brain being told that you're moving when you're really not moving, and your poor brain
Yes.
doesn't know what to do with that information. So your brain is saying it's so when you think about vertigo, there are only three parts of the human body that can generate vertigo: the inner ear itself, the nerve from the inner ear to the brainstem, and the brainstem itself. So all vertigo comes from one of those three areas. And the trick with vertigo is figuring out where is it coming from. So if it's coming from the inner ear or the nerve from the inner, we call that peripheral vertigo. If it's coming
Mhm.
from the brain stem or the near nerve just coming off the brain stem, we call that central vertigo. So MS can cause vertigo. It's more common for vertigo to be from one of those peripheral etiologies. So it's like from the inner ear. So when people talk about crystals, what they mean is in the semicircular canal. So inside our inner ear, we have little fluid-filled canals. There's one that goes straight up and down. There's one that's horizontal, and there's one that's at a 45-degree angle. And they're filled with fluid and little cells called hair cells that when we move one direction or the other, those hair cells are moved by the fluid, and it tells your body, am I moving up, down, sideways? Not at all. What we think happens in some people is they get little calcifications in those fluid canals. So you move, the hair cell is triggered. Now you're not moving. And now, unfortunately, that little grain of calcification comes along and triggers that hair cell again and tells your brain you're moving when you're really not moving. So when that happens, you get nystagmus. Your brain is trying to follow something as if you're on a train or a moving bus. It's saying, okay, my brain says I'm moving, but I can see I'm not moving. And so you get these bouncy eye movements or nystagmus. Vertigo in some people can be extinguished through those exercises that you were talking about. So we broadly call those vestibular exercises. There's something called Brandt's exercises. There's a Hall Pike. There are lots of different versions of those exercises. And what we're basically trying to do is kind of cruelly bring on your vertigo through that maneuver and then wear it out. Have you do that maneuver again and again and again to just wear it out. In the right person, they can be really effective. They tend to be more effective for peripheral vertigo. So we use the term benign positional vertigo, which is the most common type of vertigo. Again, one of the first goals in people with MS with vertigo is to try to sort out, is this your MS causing the vertigo, or is this not related to your MS? Sometimes it's a guess, and we don't always know. Vertigo from MS, because it's usually due to a brainstem lesion, you may have other symptoms that go along with it: numbness in the face, hearing loss, other things because of that brainstem lesion. But in all fairness, sometimes it can be an educated guess as to whether it's your MS or whether it's peripheral.
All right. Another question we have, I have optic neuritis, but have never received treatment. Can treatment make this better?
So if you've had optic neuritis and the symptoms have been present for more than 6 months, we don't usually think that coming in now with steroids, because what the steroids are designed to do is to treat acute inflammation. And the acute inflammation with optic neuritis, like most MS relapses, is probably gone on its own after about 4 weeks. Now, there was one study that looked at using IV immune globulin in people who had old optic neuritis. So these were individuals who were at least 6 months out from their optic neuritis, and they still had visual loss. And what they did in those individuals is they said, okay, we know steroids are not going to do much. Let's try the IVIG to see if it might still do something. And in about 50% of people, it did give them a little bit of visual recovery. So we don't think it was treating active inflammation. We don't actually know what it was doing, but it did. So there is a little bit of evidence that even in people 6 months out, that IVIG might help with old optic neuritis.
Okay, another question from the Q&A. What treatments are available for optic neuritis if the patient is allergic to prednisone?
Yeah, so if you can't do steroids, we can do the IVIG that we just mentioned. Plasma exchange maybe, but again, plasma exchange is a pretty big deal. So that's basically almost like using dialysis to suck the bad antibodies, the inflammatory antibodies out. You've got to put in a very large IV, a central line, to do plasma exchange. And so it's done every other day for 7 treatments. So it's a 2-week course. So it's a pretty big deal. And again, usually requires being in the hospital to do that. One of the questions that does come up for people who can't do steroids is, could we use ACTH? One of the brand names for that is Acthar Gel. So ACTH is what we used to use back in the 1960s and 70s very commonly before there were any synthetic steroids. So ACTH is a hormone produced by your pituitary gland that tells your adrenal glands to make natural steroids. And so the old way of using ACTH was 2 weeks of daily intramuscular injections in a kind of a slowly tapering course. The way ACTH is used now is 5 days of subcutaneous injections, 80 units of ACTH daily for 5 days. There are individuals out there that cannot tolerate steroids that can do ACTH or Acthar, again, one of the brand names. Acthar has gotten a little bit tricky. It's medically, we like it. We think it's an alternative for people who can't do steroids. It's gotten so very expensive that we have to fight quite a bit with insurance carriers. Up until 2007, the vial of Acthar Gel that would allow you to do that 5-day course was about $1,500 for the vial, which cost-wise is about the same as doing 3 days of IV steroids. With IV steroids, the drug is really cheap, but you have the nursing administration costs, which in a lot of instances ended up being about $1,500. So it's kind of either way, it was about $1,500. The cost in 2021 of that same little vial of Acthar Gel is about $45,000. There's been a little bit of inflation with that drug, and so we know that we're going to have to do some serious fighting with your insurance carrier to get that approved. But that is medically an alternative to steroids.
Okay, we have another question from Rita. Her hand is raised. Rita, you can go ahead whenever you're ready.
Well, hello, Dr. Thrower.
Hey there.
I am calling to let you know that I appreciate all the questions that people have about optic neuritis. And I was first, when I was first definitively diagnosed with MS, my first symptom was optic neuritis. And I definitely went through the treatment of the methylprednisone and the tapering off with the oral prednisone. That was helpful at the beginning, but now I'm finding that after using Acthar, plasmapheresis, and can't think of the other one I've done, my vision is still diminishing, and even with refraction, it's not improving. And so I guess my question to you, Dr. Thrower, is that are you seeing anything that potentially in the horizon may be helpful for nerves that are deteriorating
Yeah.
and may have some regenerating qualities for the optic nerve?
Yeah, I think you asked the $1 million question. So I think when you think of someone's vision slowly getting worse when they've had this old event of optic neuritis, that's kind of the same situation that we see, I think, across the board in a lot of people with MS. So every day we see individuals who say, my MRI is stable, I'm not having relapses, and yet I'm still getting a little bit worse. And we think that what explains that is loss of neural reserve. That with normal human aging, we had a base injury, optic neuritis or another MS relapse, and now with normal human aging, we're losing that neural reserve. Cells are dropping out, and so now the symptoms are looking worse not because the underlying MS injury has happened, but because now normal human aging is making it more obvious. So putting people on another anti-inflammatory or a more potent disease modifying therapy may not be the answer in that situation. We need something that regenerates nerves. And so we need something that either makes the MS lesion smaller or that keeps our neural reserve higher overall. So that's the whole concept behind neural repair, and I do think it will happen. It's the holy grail of MS, like it is in so many other neurological conditions, spinal cord injury, brain injury, Alzheimer's. So it is moving along. I would say that optic neuritis is frequently the model that they use to test neural repair strategies, because visual acuity is so easy to measure, and we can measure the optic nerve, the retinal nerve fiber layer with this OCT testing. So a lot of these studies do focus on optic neuritis. We were selected at Shepherd Center about 2 months ago as one of 2 sites in the United States to do a mesenchymal stem cell infusion trial to hopefully generate neural repair and reverse disability. So the first human for this MSTEM trial, we infused about 2 weeks ago. We have another lady we just screened today, who will hopefully be the second human being. We don't know. This is a phase 1 study. So these are the first human beings that have ever received this particular line of stem cells. So fingers crossed that we're on the right path to reversing disability, including optic neuritis.
All right, we have a few more questions. And we're going to stick with the vision questions, but there are some questions that are off topic that we'll get to at the end, if that's all right. But the next question, when it comes to vision, is there any evidence for plant-based diet helping to prevent any serious eye issues?
So offhand, I don't know of any studies that have focused specifically on the eye issues. I mean, certainly there are studies looking at diet and health overall, and multiple sclerosis. One of the common questions we get with MS is, what's the best diet for MS? I think there's good evidence that plant-based diets are probably anti-inflammatory, and so although I can't think of a study right offhand that says a plant-based diet, led to less disability or less relapses, you would think it's probably a good thing. Certainly, from a more holistic standpoint, people with MS tend to not die from MS. They die of heart disease, cancer, and stroke. So things that we do that are healthy for us overall are going to have other dividends, even if it doesn't directly impact MS. So yeah, I can't think of a study right offhand that showed that there was a direct visual impact of a plant-based diet, but I certainly wouldn't discourage anyone from pursuing it.
Okay, and this is from Stephanie. She says, "Hi, Dr. Thrower. I enjoy your talks and have relapsing remitting MS and have had COVID in the last year. I wasn't hospitalized for COVID and still have symptoms. I was not on a DMT because I was stable. Now I'm on a Baggio. I've had fuzzy vision with occasional double vision. I've been really tired more than normal. Do you think this is my MS or just fatigue? Thank you."
I definitely wouldn't write it off to just fatigue. Double vision is a pretty distinct symptom, and we all get tired from time to time, but most of us don't get double vision when we get tired. So I would definitely run that by your neurologist. They may want you to touch bases with an ophthalmologist. Sometimes when people say they have fuzzy vision, that can still be a form of double vision, because if the images are actually not so separated, let's say that there's just a little bit of a double vision. Sometimes people interpret that as blurred or fuzzy vision. So it could be that your fuzzy vision is also a form of double vision. I would definitely get someone to check that out.
Okay, and this is another question. Because of damage from optic neuritis for many years, my eyes do not work together well for reading and viewing. When tested, my vision is perfect, but I cannot use together. What are other options since Prism lenses do not fix this? As soon as glasses are taken off, my eyes are worse.
Yeah, so it's interesting. You can have visual problems and have perfect visual acuity. So this is an example where someone's visual acuity, if they put the eye chart in front of them, they're going to be able to read, 20/20, but the eyes are not tracking together. Or maybe when you try to, so when you read something up close, your eyes have to converge, they have to come together, and it's possible that that's part of the issue. One of the things I didn't mention earlier, but is a tool in the toolbox to help people, is using a low vision clinic. So low vision clinics are specialized, eye specialists who are going to look at issues like that. And they tend to, I almost think of them as being kind of like the occupational therapist of the eye world. They want to help you with activities of daily living. What is it that you're struggling with, whether it's driving, reading, keyboarding, whatever, and how can they come up with strategies to help you do a better job of it? It may be at the end of the day that there's not a lens or a prism or a medication that can fix that. So they may need to look at adaptive strategies, bigger, print, bigger screens, a lot of different technologies that we can use to try to help get around that.
Okay, another question. I'm finding that my night vision has not come back as well as the rest of my vision after relapses. And even during the day, I have a harder time seeing in darker rooms. I'm 40 something and have transitioned to needing readers in addition to my regular glasses. I'm assuming my poor night vision is MS related. Am I wrong?
Maybe not. Again, that's definitely one where you want to get in with a good eye doctor and make sure there's nothing else going on. So the readers, again, that would not be MS related. That's again one of the more common just age related eye issues that we see. But poor vision at night, it could be the MS that's doing that, but other things can do that as well. People with subtle cataracts will say that they have a more difficult time at night. Sometimes it's just difficulty with not enough acuity, but sometimes people will say there are halos around things. So again, that would definitely be one where we want to get some input from our ophthalmology colleagues to make sure that we're not missing something else.
Okay, and that appears to be all the questions we have specifically related to vision. If you have some time for some off-topic questions for a few minutes, all right. And I'm not sure the name of this medicine. It's clemastine.
Clemastine, yeah.
All right. What is the hope for this medication?
It kind of went dark. So clemastine was part of that UC San Francisco project where they were looking to look at off-label drugs, so looking at any number of things to see if they might generate neural repair, and they were using this test tube model to sort of screen these drugs very, very quickly. And so clemastine was identified in this test tube model. They took it to a study of 50 individuals with optic neuritis to see if they could get some visual recovery. And at least in this open label small study, everyone got some visual recovery. I've not seen any further data on the clemastine. I don't know if they did another study and it was negative and just didn't get published. Clemastine is an antihistamine. It's fairly benign. The most common side effect they saw in the UC San Francisco study was drowsiness. They are using it at a larger than normal dose, so it wouldn't be too unusual to see a little bit of drowsiness with it. So yeah, it was a great start to the study. I just haven't seen any follow-up on that.
Okay, another question. Let's see. And this is from Facebook, I believe. I've had MS and have a question. Does MS cause shingles? Because I have shingles right now. And then someone pointed out that chickenpox causes it, and she added, I know they said that my MS has caused the shingles to spike up. Just wanted to know if it's true.
Yeah, so there's not a direct correlation. So chickenpox is in the herpes virus family. And unfortunately, any of the herpes viruses, chickenpox, cold sores, genital herpes, they're with us for life. Those viruses live in our central nervous system and they hang out there forever. So when you have an outbreak, let's say it's a cold sore, let's say it's shingles, what's happening is that virus is using a nerve just like a highway. It's traveling from the what called the dorsal nerve root ganglion near the spinal cord, traveling down that nerve just like a highway, and boom, breaking out at the skin level where there's shingles or a cold sore or genital herpes. So there's not a direct correlation between MS and shingles. Some of our MS medications, if they are compromising your immune system, could put you at a little bit higher risk for shingles. If you are really, really stressed, so a lot of times shingles acts up during periods of emotional stress, when you're just really, really worn down, you could say, well, maybe there's an indirect correlation. If something's going on with your MS that puts you under a lot of stress, that can make shingles flare up.
Okay, and two more questions, so we can finish up. Can a pituitary cyst affect my MS? I've requested a referral, but was told that the cyst is stable.
Yeah, so benign pituitary cysts are a pretty common incidental finding on MRI. They would not directly affect your MS. If the cyst was affecting pituitary function enough, you could have hormonal irregularities that might indirectly affect your MS. And the other, if the pituitary cyst was large enough, because your pituitary gland sits right on top of your optic chiasm where the optic nerves kind of divide up. Yeah, if it were large enough, it could cause some visual changes, but most pituitary cysts are benign, and they're just something we check up on MRI periodically, usually at the same time we're following up with your MS.
All right, and final question, not related to vision, but Hope wants to know if she needs to wait 7 months for the COVID vaccine booster if she has underlying conditions.
Yeah, this is another $1 million question right now, and there's a lot of unknown. So I would back up and say that we use the term third dose and booster almost interchangeably, but they really do mean two different things. So when we talk about third doses, that's what people who are immunocompromised would receive. And so typically with Pfizer or Moderna, you're getting 2 doses of that. If you are immunocompromised, it's possible that maybe you didn't get as much of an antibody response with those 2 doses, and maybe doing a third dose 28 days or more later after your second dose will give you a little extra bang for the buck. So if you are immunocompromised in some way, then we're talking about third doses of Pfizer or Moderna. When we say a booster, that would be the term we would use in people who don't have an underlying immune problem. And that's where we're thinking about the 6 to 8 month mark from your second dose. That's very much in a topic of discussion. The FDA has not officially signed off on it yet. There's data out of Israel that suggested that it's a good thing to do. I think we'll have better clarity on that in the next few weeks as the FDA makes some sort of final determination. The poor redheaded stepchild in all of this is Johnson & Johnson. So there just is not a lot of, so we talk about third doses. Well, there's only 1 dose of J&J. So there's just not a lot of data on J&J out there right now. People have talked about mixing products. Well, if I receive J&J, I'll do a Pfizer, second dose or booster dose. There really is no data there. Personally, I'm not comfortable yet mixing products, even though in theory it may be fine. I just don't think we know enough yet to start mixing and matching the different COVID vaccine products. And it's not like in the United States, at least, that there's a massive shortage of these things. We have plenty of this stuff to go around. I think the data just needs to sort itself out. Right now, if you are immunocompromised, if your MS doctor says, I think that due to other health issues or an MS therapy that you're on, I think that your immune system may be compromised, they may talk to you about doing a third dose right now of Pfizer or Moderna. We are with some of our patients right now. And again, that third dose can be done 28 days or more from your second dose of the Pfizer or Moderna product.
Casey asked me to ask you to clarify who with MS is immunocompromised.
Yeah, that's the third $1 million question. It's a very gray area. I think we worry about people on B cell therapies. So that's going to be your Ocrevus, Rituxan, Kesimpta. We worry a little bit about people on S1P drugs. So that's going to be Gilenya, Ponvory, Mayzent, and Zeposia. Potentially patients on Mavenclad, on Limtrada, they could be potentially immunocompromised. People on any of these medications are having labs done on a regular basis to look at their immune system. We're trying to do our best to make sure that we're treating the MS without whacking the immune system too hard. And it is a very gray area to say, okay, at what point is a person on one of these drugs not immune competent? We know that patients on, for instance, the B cell therapies and the S1P drugs, a lot of those patients don't make a good antibody response after COVID vaccination or after COVID infection, but they do appear to make a good T cell response. Is that enough? We don't know. And so that's the discussion we're having with those patients. I do think that those patients are potentially immunocompromised and should give some thought. So patients on B cell therapies and S1Ps, Mavenclad or Limtrada, I do think those patients should give some strong consideration to getting a third dose of the Pfizer or Moderna product.
All right. Well, thank you so much.
Yep,
We
thank
appreciate
you.
it. And that's all the time we have for now. If you missed any part of this conference, it will be replayed on msfocusradio.org, available on demand on our MS Focus SoundCloud page, and also our YouTube channel. So make sure you check those out and join us Thursday, September 23rd at 3 p.m. Eastern for Sexual Health and Intimacy with MS, and Tyler Brown will be hosting that. Follow MS Focus on Facebook, Twitter, and Instagram for times and access information, also to sign up. And also please make sure to fill out the survey that will pop up after we log off. Our sincere thanks to everyone who attended today, and especially to Dr. Thrower. Thank you so much again for your time and taking time to prepare this. Do you have any final thoughts?
No, just everyone stay safe and healthy. We're all looking forward to life being more normal someday. We will get through this, and just take care of yourselves and looking forward to more normal times.
All right.